Thank you very much for the invitation to speak today. And I'm going to present on some new data that's just come out. And during the COVID pandemic, I've been involved with a number of clinical trials over time, and of outpatient trials that I've either led or directly or been the senior investigator or otherwise involved. We've done hydroxychloroquine, we've done ivermectin, fluvoxamine, inhaled fluticasone, montelukast, and metformin. And so I don't want to talk about hydroxychloroquine or ivermectin, but I do want to talk about metformin today. And I'm going to kind of go through some new data. And you may have seen in August that our team had published this trial in the New England Journal. This was a factorial randomized trial that looked at metformin, ivermectin, or low-dose fluvoxamine. That trial presented the 14-day outcomes, and the primary endpoint was a composite of hypoxemia, emergency room visits, hospitalization, or death. That primary outcome was null, and the major limitation was that the self-reported pulse oximetry data was really inaccurate. And while the trial came out, the US FDA said, oh, by the way, the pulse oximeters that we've approved may not be very accurate and shouldn't be used for medical care, which is a little bit odd. And so, but we were stuck with that primary endpoint, and so that was null. But if you looked at sort of the other parts of the composite, there was a 42% reduction in emergency room visits, hospitalizations, or death, and that was a statistical result. And so what you may not have seen is yesterday our group published the long-term outcomes that looked at the prevention of long COVID. And so this came out in Lancet Infectious Diseases yesterday morning here and looked at basically the 10-month outcomes after randomization and the incidence of long COVID. And so that's what I'm going to talk about. And so just to back up a little bit for those unfamiliar with the trial was a factorial randomization. It was a 3-by-2 randomized design. We enrolled people with COVID symptoms for less than 7 days, adults who are age over 30, BMI greater than 25, which would mean overweight or obese, which in the United States is about 75% of the adult population. And they were randomized either, 1-to-1 to metformin or a matched metformin placebo. Then the other randomization was ivermectin, low-dose fluticasone, or placebo. For purposes of the trial, the second randomization, ivermectin, fluticasone, and placebo didn't do anything. And so really the trial is about metformin versus placebo. And so overall, this is sort of there was 6 groups. The primary endpoint was this composite. The secondary endpoints looked at outcomes through 28 days, looked at symptom severity over time, and looked at long COVID 9 months after the acute outcomes. And so why metformin? And so for most physicians in the room, you're aware that this is a diabetes medicine. For physicians in the room, you're also kind of aware that it's kind of a weird medicine, has a lot of other sort of things that it's used for. And so it actually has antiviral activity, and this was discovered back in the 1920s. It was studied initially for influenza and has been used in the UK since the 1950s, in the US since the mid-1990s. There's sort of anti-cancer, anti-aging, lots of things, sort of interest in the medicine. And about 10 years ago, there was a number of in vitro studies that looked at antivirals. And so in vitro, there's efficacy against dengue, against Zika, against Kaposi sarcoma. There's some adjunctive hep C data. And then it's also been used as immunomodulatory therapy, and there's ongoing trials with TB, with leprosy. And there's also a lot of observational data that people on metformin have better outcomes with community-acquired pneumonia, with influenza. And so it's a little bit vague as to exactly what does this mean? And so, but there's a sort of this plethora of data. And so if you sort of dig into the in vitro activity, it's known to be an mTOR inhibitor, and via sort of the AMP activated protein kinase is thought to be the mechanism of action, that it has this indirect host directed antiviral response. And so in vitro, there's a dose-dependent inhibition of SARS-CoV-2 as well as other RNA viruses. And so while I'm talking about COVID today, realizing that this may actually have activity against other RNA viruses in the future. And so this may be sort of a potential either mechanism of other drugs that could work on the same target or the same pathway, as well as metformin potentially used for other viral infections in the future. And so in our trial, so does this actually work in humans? Lots of things work in vitro, in a petri dish, or in a test tube. Does this actually work in humans? And so within our trial, we had participants collect nasal swabs on day 1, 5, and 10. And so about 1,000 people return these swabs. And so when we looked at the viral clearance over time, there was an antiviral effect. So this is in humans in the randomized trial. The overall effect was about a 0.56 log reduction. And so that's, if you convert log sort of units into fold increase, that's about a 3.6 fold increase. You say, well, what does that mean? And so it's in the sort of the same ballpark as Paxlovid. And so in Paxlovid, for unvaccinated people who started within 3 days, the log reduction was 0.8 logs overall, and was 0.7 logs if you started within 5 days. And so if you looked at the unvaccinated participants in our trial, the log reduction was 0.77. So it's in the same ballpark-ish as Paxlovid if you compare it in apples-to-apples comparison. And unlike Paxlovid, where you stop on day 5, and the drug has a very short half-life, the antiviral effect increased over time. And so it was larger at day 10 than it was at day 5. There was also less rebound at day 10 than at day 5. And so the proportion of undetectable virus also increased over time. So it's a modest antiviral effect, but it's within the realm of other medicines, which is kind of surprising for a $1 medicine. And so the mechanism of action here is probably an antiviral effect, but there's also immunomodulatory mechanisms. And so what does this sort of lab finding of some antiviral activity actually mean? And so when you go back to the 14-day outcomes that we reported in the New England Journal paper, overall the primary composite was null, and that was really driven by the hypoxemia data, which was, as I kind of mentioned, sort of junk. But when you look at ER visits, hospitalizations, and death, there was a statistical reduction. And hospitalizations and death, it was a 53% relative reduction, was not statistically significant in the modified intent to treat population. If you looked at the intent to treat population, so everyone that was randomized, actually the hospitalization and death was statistically significant. And so this is sort of buried in the appendix, and so how the journal edited it was basically very much conveyed as a null trial. And so this is the 14-day outcomes, but what about the 28-day outcomes? And so when we designed the trial, we picked 14 days because at the time people were doing 14 days for outcomes. And so what we should have done was 28 days, because by 28 days, hospitalization in the modified intent to treat population, as well as the intent to treat population, there was a statistical reduction in hospitalization. And so this was a 57% reduction in the risk of hospitalization in this population. The trial overall enrolled about half the people were vaccinated and half were unvaccinated. And so, it's a statistical reduction. So that's the sort of the acute endpoints. And then we followed participants through 10 months of follow-up thereafter. And this is an opt-in, and so they could stop after a month. But the majority of people decided to follow up, and they basically completed monthly surveys through 10 months. And of those who agreed to follow up, about 95% of them at least completed 9 months of follow-up. And basically, we asked them about their ongoing symptoms, and then after 6 months, we asked them if they had a physician or a healthcare provider a diagnosis of long COVID. And so our case definition here was that you had ongoing symptoms, which would be consistent with sort of WHO criteria for long COVID of having symptoms after 60 days. And you had a physician who actually was blinded, so it was a regular physician who evaluated the participant, theoretically should have excluded alternative diagnoses, and then we verified those records. And so we asked for medical records for everyone that said that they had been diagnosed by a physician or by a healthcare provider. Majority were physicians. I think there was one chiropractor. But and so what was the timing of diagnoses? And so the symptoms were ongoing, but this is when people were diagnosed. And so overall, it was basically a little over 10% incidence in the placebo group. So this is a identical matched placebo versus 6.3% with the metformin group. And so that's basically a 4% absolute reduction and a 41% relative reduction in the incidence of long COVID over time. And so this is the time of diagnosis, but the symptoms would have been ongoing from their initial infection. And so that's a statistical reduction, and is kind of impressive. So this is kind of considered quadruple blinded, where the patient remained blinded, the investigators remained blinded to the assignment, the evaluator, the physician who was evaluating also was blinded, and the outcomes assessor. So, and so if you look at the type of symptoms, this is consistent with other long COVID symptoms. It's a little bit of a small font, but the major symptoms, fatigue, sort of the brain fog, insomnia, headache, anosmia, depression, myalgia. And so in the blue bars are the people who had a healthcare provider diagnosis of long COVID, and those who didn't, there was a low level, 5-10% of other sort of symptoms that were reported over time. And if you ask the general population, do you have insomnia, do you have problems sleeping? Certainly, a proportion of the population at any given time will have that. And so this is the average symptom frequency over the 10 months of follow-up. And what was the impact? And so was this kind of annoying, or was this actually a major impact to their life? And so when we looked at, did this actually affect their ability to work or affect their leisure activities? It was, slowly decreasing over time, but really persisting. And so that sort of about half the patients, half the participants had some impact of affecting either their work or leisure activities. And that was much higher than those who didn't have a long COVID diagnosis. And the effect was consistent across subgroups, and so subgroup analysis, I wouldn't dig into like, oh, this was slightly more or less, but overall the consistency was there. I'll point out two different things here. One was, if you look at those who started earlier, so those within 3 days, the effect was potentially larger, was up to a 73% reduction. And that would be kind of consistent with an antiviral, that the earlier you start an antiviral, likelier the more effective it is in COVID. The other thing that people point out is that the effect of the vaccinated subgroup was a little bit less than the overall, and I would sort of caution that these are subgroup sort of analyses, and so if you cut it slightly differently, so in this case, the overall effect was a hazard ratio of 0.85. If you take instead the boosted and vaccinated within 6 months, the hazard ratio would be 0.66, and so you can kind of cut things differently and sometimes sort of get different results. And so overall, consistency was sort of across the subgroups was all in the favorable direction. And speaking about sort of odd subgroups, I sort of point out an older trial back from 1988 when you looked at aspirin for myocardial infarction. If you looked at sort of astrological signs, those with the Libra or a Gemini, didn't benefit from aspirin in a myocardial, acute heart attack sort of model. And so if you can always in a large trial pull out some subgroup that didn't benefit. And so I think that I wouldn't overinterpret any of the subgroups that we published on that. And I want to acknowledge James Watson from OCRU in Vietnam for this analogy that he provided a couple weeks ago to me. So in summary, metformin, it's safe, it's inexpensive, and it's widely available. And so a month of therapy is probably it's sort of $4 US cost, available worldwide. Most general practitioners have a lot of experience with it. As an infectious disease doctor, I haven't really prescribed this actually since my internal medicine training. And so my wife, who's a general practitioner, is actually much more familiar with metformin than I am. Overall, it has few drug-drug interactions. It doesn't interact with Paxlovid or molnupiravir. And so, in theory, you could combine those if you wanted to. There's really relatively few contraindications. It's safe in pregnancy, and this trial actually enrolled pregnant women. And there's really no follow-up monitoring needed. And so this was given just for 2 weeks of initial therapy up front and was well tolerated. We did titrate up the dose over several days. If you give a bunch of metformin all at once, you'll get sort of nausea, abdominal bloating, and diarrhea. And so we titrated it up over 6 days, and most people tolerated it okay. And so lastly, just to kind of summarize sort of the data that we found in this trial, and I would encourage you to look at the publication that's now out in the Lancet ID. So overall, there was an antiviral effect. This increased over time, and it decreased the amount of rebound that we defined as viral load higher at day 10 than day 5. There was a reduction, 42% reduction in ER visits and hospitalizations in the first 2 weeks, a 58% reduction in hospitalizations over the first 28 days, and a 41% reduction in long COVID, and perhaps a greater effect if the medicine was started earlier. Overall, the cost of 14 days of therapy, which would be 36 tablets, of the immediate release, or the old school immediate release formulation, was about $1 US. Maybe it's more expensive locally, maybe it's $2, but this is a very inexpensive therapy compared to Paxlovid or some other therapy, and it's available worldwide in low and middle income countries. And so I think this is a really good option, particularly if you don't have access to Paxlovid. And the data on prevention of long COVID, I think, is much better than Paxlovid. So Paxlovid has case control studies where there was a 26% reduction in a case control study. This is a 41% reduction in a randomized double-blind placebo-controlled trial. And so I think this is an option to consider and something you can discuss with patients. And I would look forward to answering questions on the panel later on.